So, good afternoon again on behalf of Division of Trauma Surgery and Critical Care. And to level up the illusion, now I present you again illusion, that is surgical illusion, elusive hemothorax. So, in high acute setting, be it the medical or war front or aviation, we always say that don't use your mind and follow the protocols. But there are some situations which test your nerve and don't fall within the line of this dictum. So this is one challenging case, rarest of the rare entity, which tested our nerves, forced us to stretch our resources as well as to bend our own protocol, established protocol, time-tested protocol, to find out what is wrong and how we manage. To unfold the case, I'm joined by three brilliant people: Dr. Piyush, senior resident from the Division of Trauma Surgery and Critical Care; Dr. Nuha from the Department of Radiology; and Dr. Sisti to present the discussion from, again, Division of Trauma Surgery and Critical Care. I invite Dr. Piyush to start the case. Thank you.
A very warm good afternoon to one and all. So our case is a 33-year-old male. He's a food delivery partner who was brought to ED by police in a PCR van with alleged history of RTI, two-wheeler helmeted rider hit by four-wheeler. He sustained injury at 4:40 a.m. in the morning of 1st of January and arrived to our center 34 minutes after injury. Initially, he was triaged red. As per our protocol, we proceeded with our primary survey, which revealed that patient had tachypnea with right side air entry decreased. He also had tachycardia. Resuscitation was continued. Further adjuncts were done, in which chest X-ray revealed that patient had right-sided hemothorax, further confirmed by EFAST, which also revealed the same finding. So, right-sided intercostal drain was placed, which revealed around 500 ml of hemorrhagic output. There was no air leak that was noted, and X-ray revealed that there was complete expansion of lung post ICD placement. At this time, patient was hemodynamically stable with improvement in tachypnea, and ABG parameters were still showing metabolic acidosis with raised lactate and base deficit. We continued the resuscitation and proceeded with secondary survey, which revealed that he had multiple soft tissue injuries over scalp and face, for which compressive dressing was done. He also had open grade 1 injury over right side both bone forearm fracture. He had right side tibia fracture closed and right side bimalleolar fracture that was also closed. For all these fractures, splinting was done as primary management. Meanwhile, we were doing the secondary survey. Patient's output, ICD output, increased from 500 ml to 1200 ml in within 15 hours of placement, placement of ICD. And patient worsened hemodynamically. Patient had a fall in BP, increase in tachypnea, and ABG parameters further worsened with increase in lactate and base deficit level and fall in hemogram. Damage control resuscitation was initiated in view of grade 4 shock. Patient had a threatened airway. Patient was intubated. Major hemorrhage protocol was activated, and as per our protocol, 2 unit PRBC, 2 unit FFP, and 2 unit RDP was transfused. The next question was where patient was bleeding from. So we have a dictum in trauma that whenever a major bleeding is there, it is either on floor or four more. On floor means that patient has external hemorrhage, which in our case was not. So patient was bleeding from one of the four more sources. One is the chest. We already know that patient had hemothorax and we have placed an ICD over it. Other is abdomen, for which we have done fast and which revealed that there was no free fluid in abdomen. Third is pelvis, for which X-ray has shown that no bony injury was there, and extremity fractures are all splinted. So the only injury that was concerning was the chest, for which patient with even with resuscitation, patient was not responding, hemodynamically remained stable. Patient was declared transient responder and shifted to OT for damage control thoracotomy. In thoracotomy, we did right side anterolateral thoracotomy, and 500 ml of hemothorax with clots were removed. So in this thoracotomy, there was no other injury to lung, thoracic cavity, or upper mediastinum. There was a minimal oozing that was seen coming from posterior cardiophrenic recess. This recess is deeply seated inside the chest cavity. In this schematic diagram, we could see that it is deeply seated just above the diaphragm. So, but with minimal cauterization, we were able to achieve the hemostasis this time. Patient's vital improved, uh, and inotropic support that was initiated at the start of OT started to taper down. By this time, we have transfused patient with 4-unit PRBC, 4-unit FFP, and 6-unit RDP. But since patient was improving, we closed the thoracotomy wound and planned to shift the patient to ICU. But meanwhile, while we were planning to shift the patient suddenly worsened. So after patient suddenly worsened, and there was increase in dual inotropic support. And what could have gone wrong with the patient? We have closed the cavity, which was dry. So we reassessed the patient. At this time, we did fast again, which revealed no free fluid in abdomen. We could see that ICD is in place and only 200 ml of ICD output was there. There was no column movement, though. Anesthesia team at this time did point of care ultrasound and found out that right side hemothorax is still present with significant amount of clots. So the cavity was re-explored, and around 1.5 to 2 liter of hemothorax was evacuated. This time there was active bleeding that could be seen arising from posterior cardiophrenic recess. We did packing this time, but even with packing, patient was deteriorating hemodynamically. He was quickly started to dual inotropic support, which was still increasing. By this time, patient underwent 6 and 8 transfusions. So what could be the source of this bleeding? How should we approach this bleeding? It is deeply seated inside this cavity. We needed better exposure. So we extended our exposure this time to contralateral chest to evaluate pericardium as well as contralateral chest. We did bilateral thoracosternotomy, which is called clamshell thoracotomy. In this procedure, we could evaluate all the 3 cavities here. We could not find any injury in the pericardium and heart, and we could not find any injury in the contralateral chest. But patient was still deteriorating. Patient by this time was on triple inotropic support, and ABG parameters still worsened. So the source was still elusive. What could be the source of this bleeding? At this time, we decided that we'll get a CT done in a unstable patient. We informed radiology team. We informed the red area and yellow area to keep the gantry open. We made the corridor. We made all the efforts. We made all the preparations to shift an unstable patient on triple inotrop to get a CT done. By this time, already 4 hours have passed since the patient has arrived. Now, I would like to call Dr. Neha to come and discuss the CT findings.
Good afternoon, everyone. So finally, a dual phase contrast enhanced CT of the torso was done for this patient in the post-op situation. And here we can see that there is bilateral hemothorax as well as, So there is bilateral hemothorax as well as pneumothorax and pneumomediastinum. There are chest tubes in situ in bilateral thoracic cavities. There is surgical emphysema in the right lateral chest wall. In the abdomen, we could see that this was the arterial phase images in the maximum intensity projection. And here is the abdominal aorta, and this is the site where we expect to see the celiac artery origin, which is not visible. Instead, we see an irregular shaped contrast density adjacent to it. And these are the venous as well as the delayed phase images at the same level. So we can see that this contrast fill density was changing in shape, becoming more irregular, and there is an increased density in the right hemithorax in the right pleural cavity. And on the delayed phase image, you can see that the contrast is spread in the entire right pleural cavity. So these findings are suspicious for a celiac artery avulsion with active contrast extravasation extending into the right pleural cavity. And these are the reformatted images. So on the sagittal reconstruction, again, we can see that this is the abdominal aorta. This is the normal origin of the superior mesenteric artery. And just above it is where we expect to see the celiac artery, but that is not visible. And there are these irregular contrast densities extending up to the right pleural cavity. Again, seen on the coronal maximum intensity projection, the renal artery as well as the superior mesenteric artery are normal. And this image shows that the branches of the celiac artery, that is the common hepatic as well as the splenic artery, were being filled by collaterals from the superior mesenteric artery. So again, the volume rendered image showing the celiac artery avulsion as well as active contrast extravasation from it. And these were the other bony injuries that we have already discussed, indicating the high impact of trauma. So comminuted fractures in the upper as well as lower limb long bones.
Thank you, Dr. Neha. So now we knew that the patient is bleeding from zone 1 retroperitoneum high inside the thoracoabdomen. This is the area which is difficult to approach. By this time in CT gantry, patient was still worsening. His BP was falling and tachycardia increasing. Patient already had maximum triple inotropic support. By this time already patient underwent 14 PRBC, 10 FFP and 10 RDP transfusion, and 4 hours and 40 minutes have already passed. So patient was quickly wheeled in again for laparotomy. This time, because we have already done a clamshell thoracotomy, we could easily get a control of proximal aortic control. This zone 1 bleeding that was coming from celiac artery is high inside zone 1 and deep inside thoracoabdomen. So for this, approaching this bleed, we had to do a maneuver in which left-sided viscera are lifted off the retroperitoneum along the line of Told and put over the right side. This is called medialization, which can be seen. It's done in 3 steps. And once kidney is completely lifted off, we could see all the 3 major vessels, superiormost the celiac, then SMA, and then renal arteries. So in this image, we can see these 3 arteries clearly. So I would like to magnify it. So there is celiac artery. In our case, it was completely avulsed, so which was causing the bleeding. So this completely avulsed artery could be seen in this intraop image as well. So this avulsed end of celiac trunk was ligated. The rent in aorta was repaired. Around 1.5 centimeter long rent was there. It was repaired. And this was the laparotomy image in the end. So by this time, hemostasis was achieved for the first time, and patient drastically improved hemodynamically. He was now on inotropic support, single inotropic support, that too tapering. By this time, patient already underwent 20, 20, 20, and 6 cryoprecipitate transfusion, and ABG parameters showed slight improvement with slight improvement in acidosis. By this time, patients still need resuscitation, so only temporary abdominal closure with skin-only closure was done with an intent to relook laparotomy after once patient stabilizes. So patient was shifted to ICU for further resuscitation. Patient had massive hemorrhage and massive transfusion by this time. For next 24 hours, patient underwent resuscitation in ICU, and after which patient was taken for relook laparotomy. In relook laparotomy, there was no active bleed that was noted. Stomach, bowel, liver, and spleen, all the organs which celiac axis supply were healthy. So formal closure was done. Patient was again shifted back to ICU for further resuscitation. So ICU course of this patient remained stormy. Patient had all the complication known with massive hemorrhage, massive transfusion, hypothermia, hyperkalemia, acute kidney injury, transfusion-associated circulatory overload, transfusion-related acute lung injury. At the end of first week, patient had a pneumonia and surgical site infection, which were managed non-operatively. Patient had, in the second and third week, patient had persistent high-grade fever for which workup was done. Incidentally, in this, we could identify that patient also had left-sided renal ischemic changes, and he also had left lower pulmonary artery thrombosis. With the dedicated efforts by the anesthesia team of the ICU, patient was weaned off by the 4th week and shifted to ward for further orthopedic interventions. Now, I would like to call Dr. Srishti for discussion part.
Thank you, Dr. Piyush. Now, I would like to discuss this case. So, we will discuss it in 3 points, like what was so unique about this case that we are presenting on this platform. Now, what were the challenges we faced during the management of the patient? And of course, what the patient taught us, as every case teaches us something. So now we'll just have a quick review about the anatomy. We already know that celiac trunk is the first major ventral branch of abdominal aorta, Means if it is avulsed, it is bleeding from the abdominal aorta. It is just a short, thick vessel, about 1 to 2 centimeter, which supplies the foregut derivatives. Mainly, it gives 3 branches, one to the spleen with the splenic artery, left gastric artery supplying the stomach, and the common hepatic supplying the liver, as well as some part of pancreas and duodenum. So mainly the celiac artery injury is deep-seated. So the most common mechanism is penetrating mechanism. So blunt injury is seen only in the 5.9% cases of the abdominal vascular injury, of which celiac trunk avulsion is only the 0.01% of this 5.9%. So in literature, till now, we have only seen only 7 case reports. So these are all the documented case reports. We will discuss it quickly, one by one. So now, why do we have such a limited literature? Because celiac artery is located in such a depth, overlying with the liver, spleen, stomach, above diaphragm. So its injury requires a relatively high force. And most importantly, if celiac artery is avulsed, patient has acute bleeding from the aorta. So mostly the patient die in pre-hospital mortality, or they reach an extremis, those who cannot be saved, but the cause is never fully identified. So why have we chosen this case? So this case, what was this case? If we see the diagnosis, it was actually a blunt trauma abdomen with celiac trunk avulsion presenting as a hemothorax. So we were confused about the diagnosis, searching the bleed in the chest only. So this was an exceptionally rare presentation. So we have seen all the literature and nobody has reported as celiac trunk avulsion presenting as hemothorax. And it is also our first case we have encountered in our institute over 20 years. So we'll just quickly review. So this was the first case which was published in 2010. What they had was a 17-year-old male in a motor vehicle collision. Patient was initially in shock. They did primary survey, found only blunt trauma chest, for they put an ICD. But in this, the patient was fast negative only. So they resuscitated, patient got resuscitated, went to a CT scan. And after CT scan, it was diagnosed as the patient had a celiac trunk avulsion. So they took him to OT as the patient was already in shock. They ligated the celiac trunk and hence the patient was discharged successfully. This was a second case. What happened, it was reported in Korea. So they met with a patient with a blunt trauma abdomen with a steel bar injury during a construction accident. So the patient arrived in hemodynamically stable in their ED. They did CT, find out there was celiac trunk avulsion associated with a pseudoaneurysm. So they treated it with a stent graft. The patient was successfully discharged. Similar case was reported in 2013. Patient hemodynamically stable, only abdominal pain, CT done, showed celiac trunk avulsion, ligated, and patient successfully discharged. So this was also an institute from Level 1 Trauma Center in USA. They did a 5-year study taking all the celiac artery injury patient from 2012 to 2017. What they found out was only 10 patients were there in 5 years. And only 1 patient was of avulsion. That too also died due to hemorrhagic shock. So the mortality is very high in case of celiac artery injury. So these were similar cases in 2023. 2 case reports are published. They had a patient, both were in shock. One had polytrauma, one has left lower limb mangled extremity. They both got resuscitated, went to CT. In CT, they discovered they had a celiac trunk avulsion. They had a facility of hybrid OT, so they took a proximal control by a supraceliac aorta balloon occlusion. And when patient was in extremis, so they ligated and the patient survived. So this was a 3D image showing the celiac trunk avulsion. Now, this was a case, it was reported in 2017. What happened, the patient was of a 75-year-old male. So he was already an antiplatelet and anticoagulants for atherosclerotic disease. So the patient arrived in their chance, they did a CT showed celiac trunk avulsion. Now the patient in shock, they ligated, but what happened that he had not good retrograde supply to the organs, major organs the celiac trunk is supplying. So in this case, they had to do an aortoceliac bypass. Also, this case, patient survived. So this was showing the celiac trunk avulsion. So now, as we review all the previous cases, what we see was that all the patients, they arrived in shock, were either hemodynamically stable or after resuscitation, they were hemodynamically stable, so they were able to go to CT. So maybe they had a contained retroperitoneal hematoma so that they could go to CT. In our case, what happened, this retroperitoneal hematoma was seeping by the hemothorax, which was drained by the ICD. So our patient was a typically transient responder, so we couldn't get a CT. So now we'll come to the challenges that we have faced during the management. First, we already discussed was the diagnostic dilemma. As we already discussed, what we were seeing was bleeding in the chest. So in first, so we did a thoracotomy. Even though we could not identify it, we did a clamshell thoracotomy, fully evaluating the whole chest. So thereby losing our time in the actual diagnosis, which was the patient was bleeding in the abdomen. Second, as we had started the patient with damage control resuscitation, this is a protocol that 4 protocols are to be followed in a damage control resuscitation. First is permissive hypertension to keep the BP on lower side. Since the patient is bleeding, somehow some clot has formed in the artery. If we raise the BP, that clot can be dislodged, the patient can again bleed. And second, if the blood has lost, we have to replace that blood. So as the acidosis, coagulopathy, and all the metabolic, he does not go into the lethal triad. And the fourth and the foremost thing is the early hemorrhage control. Without this, all the 3 we previously discussed will be all be futile efforts. So in our case, we were stuck as this fourth part. That was the early hemorrhage control. That is close the tap because we were not able to identify the bleed. Now if we go retrospectively, what could have been done better? What would have done better to early localize this early hemorrhage control, because it took us around 6 hours to actually stop the bleed. So what else could have been done if we had an hybrid OT? See, hybrid OT is an OT with all the CT scan, all the angiography suite, and also the surgeon and OT equipments all available, so as to localize the bleed at that instant time. So it would have saved us from the time from shifting the patient to the OT, the massive blood transfusion which patient went through. So this gives us an opportunity for combined surgical and endovascular care. Rapid bleed, if we had done an angiography in the suit only, we would have localized that the patient was bleeding in the abdomen. And faster hemorrhage control would have been achieved. Hopefully we will get it someday. So in our case was कि we follow ATLS protocol. So ATLS protocol relatively does not say कि take the unstable patient to OT. Our patient was already on triple inotropic support, maxed out inotropic support, BP 60/30, already transfused 20/20 blood, but still we were no clue at where the patient was bleeding. So we had to take some tough decision regarding what to do. So we took the decision to take the patient to CT. And this CT enabled us to localize the bleed, which was actually misled by the hemothorax. So now with the help of the CT, as we localize the bleed, so now we know that the patient major artery has avulsed, which is supplying the major organs, mainly the foregut supplies. So, but thankfully our patient was young, he was not an old patient. So his collaterals were developed. So that his all organs were supplied, all those collaterals between the superior and inferior pancreatico-duodenal artery. So this was one case report reported. What happened ki some polytrauma patient was there. He had an initial CT done. So they were treating the severe head injury and bilateral thoracic injury. And on day 6, patient went into acute hepatic failure. So they could not identify the cause. They did a CT angio, and in which they identified there was celiac dissection. But by the time the patient had already gone into acute hepatic failure, so they could not save him. So the second challenge which we faced was, we already discussed its anatomy in the very depth. It is located in very depth. So as its exposure requires a complicated procedure. Getting all the left-sided viscera into the midline, getting all the ligaments opened up, which is associated with its own complication of splenic injury, lumbar veins. But we know that the patient is an extremist and we have to take this chance to save him. So in the end, lessons learned that protocols are there for 99% of the patient, but in 1% we have to make the decision based on clinical situation. Second is reassessment. Even though in first OT we thought that we had controlled the bleed, but the patient was deteriorating. So it was telling us that something we had missed in the first OT, and we have to reassess the patient, do not send him to ICU for post-op care. So this continuous reassessment helped us to localize the source which was actually hidden from us. And of course, the team effort from the anesthesiology team, from the radiology team, and of course, the extensive ICU care which the patient has received, through which now the patient can walk back to his family and hug him. So in the end, always reassess, rethink, and re-engage, because even our one effort can save one life. Thank you.
Thank you, Dr. Srishti. It is obvious about the case. Now I would like to take question from you. The house is open to questions. So actually, good question. Actually, this aorta and the celiac arteries, they actually originate from the retroperitoneum. And if you see correctly, just below the diaphragm lies the celiac. That is after the aortic. It is the aortic hiatus. So when it bleeds through, it dissected through the hiatus and went into the right chest cavity. So yes, after the avulsion, because it is just below the hiatus only. So it actually dissected through that, and though it's misled us, but at the same time, we feel that the hemothorax actually saved the patient also, because just imagine patient can bleed 4 to 5 liter in the retroperitoneum, and still there is no way we can find out in the primary survey, like by FAST or by clinical examination. So it actually gave us some pointers that there is a bleeder, but the bleeder came from the retroperitoneum, that is just below the diaphragm, through the aortic hiatus in the diaphragm. Yes, please. Any other questions? So also let me tell you, when we assess the patient in the primary survey, all our efforts are to find the bleed in that primary survey. It is obvious that CT is better for pinpointing the bleeder, but it is not possible in the primary survey when the patient is unstable. So all our mechanism like A, B, C, D, whatever we do, they are designed in a way to find bleeder from the one on the floor 4 more. This was a retroperitoneal bleed, and in the primary survey, we take pelvic fracture as an indirect evidence of retroperitoneal bleed, because it is one of the commonest. But such bleed, if they do not manifest in other cavities, it's very hard to actually pinpoint where the bleeding is coming from. Technically, it's also very difficult. I hardly have seen any. This is what we call Mattox maneuver. All your vessels and all your viscera has to be mobilized to expose the aorta. So technically, it is also very challenging to take that decision. Also, it is very challenging. Yes. Any other question, please? So thank you very much.